Bunnell.
Yeah.
Excellent. Thank you very much.
We are on time, Dr. Onida, whenever you want to start.
Okay, great. Welcome everyone. Thank you for joining us in our webinar today. My name is Sarah Onida. I'm one of the vascular residents and university staff at Imperial College in London. And normally I'd be chairing this with my colleague, Dr. Bush, who sadly can't be with us right today for this webinar, but we will look forward to having her at the next one. So I'm very excited for this compression webinar today, but before we start, we'll have a couple of introductory videos from the Vein and Lymphatic University President and Chairman. If the IT team could share these, please.
Buenos días, queridos amigos. Yo soy el doctor Víctor Canata, presidente de Venous and Lymphatic University. La plataforma y el grupo de trabajo de Venous and Lymphatic University es un grupo de profesionales de alto nivel a nivel mundial que se encuentra desarrollando programas de enseñanza, de capacitación y de preparación de diferentes tipos de webinar, trabajos humanitarios y enseñanza en el campo de las varices y los linfáticos. Este grupo de trabajo tiene una calidad y una capacidad excelente. Nos encontramos permanentemente trabajando en demostrar la excelencia y la capacitación de todas las personas dedicadas al tratamiento de las varices y de los linfáticos a nivel mundial. Por eso les decimos y les agradecemos al grupo de trabajo. Les pedimos que nos sigan en nuestras plataformas y en nuestros diferentes webinars y que se acerquen al grupo de trabajo de Vein and Lymphatic University. Generalmente lo manejamos en forma compleja, teniendo la posibilidad de demostrar el trabajo de las diferentes diversidades etnológicas, demostrando las capacidades científicas a nivel mundial. Así que, por tanto, les doy la bienvenida y espero que nuestro trabajo tenga sus frutos en relación a la capacitación, la calidad de la enseñanza y así como también la llegada a nuestros diferentes pacientes a nivel mundial. Así que un fuerte saludo para todos. Por favor, recuérdense de que la capacitación y la enseñanza es algo que realmente nos va a ayudar y va a demostrar que nuestros pacientes cada vez reciban mejores diagnósticos y mejores tratamientos en el arte del tratamiento de las varices y los linfáticos. Un saludo para todos y que Dios los bendiga.
Hello, everyone, and welcome to today's session. My name is Dr. Lowell Kabnick, and I'm the chairperson of Vein and Lymphatic University. VLU is a premier educational platform whose mission is to deliver groundbreaking, high-quality content utilizing the talents of a diverse global team of health experts focusing on venous and lymphatic disease and treatment for the medical community and its patients. The goal of VLU is to make a positive impact on the global medical community by accelerating venous and lymphatic education through highly accessible and interactive live webinars and lectures, informative videos, and other premium channels of community engagement with the aim of empowering, inspiring, and advancing understanding of venous and lymphatic disease and treatment. Our initial series is titled EmPowHER, which was developed by Ruth Bush, Sarah Onida, and Leanne Alizio. This is a series of webinars crafted and directed by our women colleagues for all. On behalf of VLU's Executive Board, we thank you for joining us.
Excellent. Thank you, IT team, for that. So I will go ahead and share my screen to introduce this webinar today. So first of all, I want to take the opportunity to thank some of our sponsors, Boston Scientific and Medtronic, for the support that they provide to Venous Lymphatic University. And today, as you know, it's our compression webinar, which is a topic of great interest, I'm sure, to us all. And we're extremely lucky to have a fantastic setup with three expert speakers. They're all vascular surgeons in the US. We've got Dr. Pounds, Dr. Lohr, and Dr. Bunnell. And without further ado, we're going to start off with Dr. Pounds' presentation on how to choose the correct compression for your patient, which will be a pre-recorded presentation, as she unfortunately cannot join us today. If the IT team could very kindly share the presentation, that'd be great. Thank you.
Good morning. I'd like to thank the Vein and Lymphatic University for the opportunity today to present on how to choose the right compression for your patient. And I'd like to thank everyone for their support on the EmPowHER series. Share my screen. All right. So today we're going to have for our objectives to understand the difference between different choices of compression, develop an algorithm for compression, and identify barriers to compression adherence. I have no disclosures. So when you think, oh no, not the dreaded compression talk, it's one of the things that we definitely do not spend a lot of time in our graduate medical education or undergraduate medical education on, but it's something that we really do need to address and talk about. And when we say compression, we're going to break it into static and dynamic. Dynamic would be, say, a compression pump, which is not the focus today, but we're going to talk about static compression. This is materials that provide a fixed compression level absent of movement. These materials can be knit, woven, wraps, or bandages. And these are then divided into elastic and inelastic. The elastics can be circular, which can be regular or stiff, flat, these ulcer kits, and even fashion and sport styles, which I have a fair number of. And then they can be inelastic. They can be adjustable wraps, different bandages. There's short stretch reusable bandages, the old-fashioned zinc paste, Una style, and 4- and 3-layer wraps. The biggest challenges as a physician who treats any superficial or deep venous disease faces is placing patients into a good compression. The sheer number of barriers to compliance is high, and they'll say they're tight, they're hot, they're expensive, they're ugly, they cut off the circulation, they fall down, they didn't do anything. The list can actually be endless of what the patient will say. There's physical barriers that the patient may have, mobility, they may have severe rheumatoid arthritis, that their hands can't actually hold the compression hose or don them. They may have problems where they can't bend over to physically place the compression hose. They may have financial concerns because they are unable to afford some of these, which are typically not covered by their insurance. So besides the fact of the subjective problems, there are many other reasons that compression hose are not just widely adopted or say as easy as taking a pill. Now, it can be a box of chocolates on why a patient may need compression, from a simple primary isolated superficial venous insufficiency clear through a C6 lymphedema, and all the things in between, including non-surgical reasons. Now, sometimes the culprit can be identified and corrected, or sometimes not. Regardless, compression is the cornerstone of what we recommend the patient when they present. And so it may be bilateral edema, unilateral, could be either. And so when you look at the patient when they present for their consult, you start going through and say, I look through their medication list as one of the first things and identify something that may be contributing to this. And so when you do that, even if I find one of the major hitters, such as amlodipine, I still recommend a compression as to help control it, and talk with the primary care doctor to switch them from a calcium channel blocker to another agent to help control their blood pressure. So when we break it down into our garment categories, we're going to start with our simple circular knit off the shelf, and the stiffness goes up to our decongestive garments. All right, so we have a circular knit, a stiff circular knit, flat knit, adjustable wraps, night garments, and then the decongestive. And if you bring one thing away from today's talk, it's that TEDs are for beds. All right, patients have post-traumatic stress issues from a bad problem, bad interaction with TED hose that weren't accurately sized, placed. Materials management do not have all the different sizes. They weren't measured correctly for many reasons. But TEDs do not provide adequate compression for someone who is not in bed supine. So if nothing else, just walk away with that today. For circular knit compression, which is elastic, it's a round knit that is seamless. They're ready to wear off the shelf. Many places will stock a fair amount of, reasonable but limited choices of sizes. They're quite elastic, nylon and lycra, and they give a fixed compression. They're prescribed by the level millimeters of mercury. So medical grade in the United States, 20 to 30, kind of our standard insurance required post-procedure that we will usually give. They're indicated from mild to moderate superficial venous or severe varicose veins, mild to moderate edema, the tired, achy legs, post-ablation, again, recovery, prevention of DVT. The 15 to 20, you'll see now marketed as airline, compression, things like that. Now here you have the stiffer circular knit. So the stiffer garment has a denser knitting pattern and more containment. You're not going to have the same level of colors and choices and little cute patterns and whatnot, but what you are going to have is more containment and more relief in a off-the-shelf, less expensive product. So most of the time I tell my patients a knee-high circular knit from a quality brand is probably between $50 to $60 for a pair, where a thigh-high will usually run $70, $80 for a pair. And if you want to get fancy with sheer colors or patterns, textures, it may be a little bit more. And pantyhose can be a little bit more expensive. If they start paying less than that, then the quality may decline. Now, when you go to a flat knit elastic garment, these are manufactured differently. They're not circular, they're on a flat machine that then have a seam where they're sewn together. And so the way this is constructed, the seam limits this longitudinal stretch, and it's certainly more containing. And so it's indicated for moderate to severe lymphedema, lipedema, or venous disease with obesity. And when we do that, you can see their stiffness. So with each one, the regular circular, stiffer circular, and the flat knit or the adjustables, each time it goes up in millimeters of mercury for their stiffness. Now, as far as adjustable wraps and decongestion, we're into the inelastic section. These are manufactured differently. They may have a breathable neoprene type of fabric or not. They're typically thicker, heavier, and they're more expensive. So they're sold by extremity instead of a pair. The majority have a Velcro style closure. They may have clasps like a bra, and the foot piece is often also sold separately. So it can become expensive, especially again, not covered usually by medical insurances for a patient, but they're indicated for moderate to severe lymphedema, mild to severe lipedema, moderate to severe venous disease, and especially ulcerations. These are quite handy for patients who have limited ability to don, or if a family member or an agency is coming in to supply the patient for to put on compression or wound care. For some patients who need more continuous 24-hour type of relief, we have night garments, and these are specific. You're really into high-end dollar specialty products, especially like these big lobules on your lympholipedema patients. And then there's also decongestive garments that, as somebody has gone through and had decongestion, these can actually be cut and modified. So that has a certain population that is even indicated for. When we talk about compression bandaging that's inelastic, there's certainly the throwaway, not reusable, such as your Una boot, which is a zinc or a zinc calamine paste that's put on with a co-band layer over top, assimilating a 30 to 40 millimeter compression. And then we also have these new multi-layer wraps that are comprised of 4 or 3 layers if there's any peripheral arterial disease, and have been shown to be efficacious for patients with C6 ulceration. Now, for our reusable short stretch, there's usually one to wash and one to wear, applied by a therapist doing complete decongestive therapy along with manual lymphatic decongestion. And this is great for that acute phase where they go on and have this done sometimes 3 times a week before they're placed into a pump. And then the maintenance type of inelastic garments, or maybe at some point, hopefully, just regular elastic garments. But they'll start down at the toes, and then they have the multi-layer garments that go up. They'll have a low resting phase and a high working phase. So how do you find all these? In your city, you have to come up with a list of places, and wherever your patients come from, of a durable medical place that has these types of compression hose. Some places do sell them, in their office, but usually, again, that's, a circular knit that's very standard shaped legs, perhaps for superficial venous interventions. When you start getting complex, it can be challenging to have that kind of volume and stock. But what I've done in my office is I have a list of places my patients have given feedback from, and some of them do have several different brands that they sell, and their contacts, and the patients sort of have to go and ask. I do have some online resources, but I very much suggest going to at least the first pair, especially if they have a regular shaped leg, and say they need to be measured, especially if it's a thigh high. And then I have resources here for donning and doffing, and some online like bainform.org resources. This is a great resource, the Stride manual that talks about the shape, texture, reflux. It's like a TMN system for how you would, for complex patients especially. And it's really worth, if you want to get further into this, downloading the manual and really looking into how they would look at it. So compression is really a continuum, from the circular knit, just regular, superficial spider vein patient, clear up to the patient with an ulcer and severe lymphedema that needs to be taken care of. And so you really have to tailor this to the patient that presents to you and be able to get them measured into the right garment for compliance. There's some great online videos. You do have to be cautious. There's a lot out on YouTube that may not be the best quality, just like anything now in medicine. So, the ones that I like, I save. I've made some QR codes even for patients to take, and they can watch to what to do. All right, thank you very much for your attention, and I'm going to turn over to our moderators.
Great. Well, that was a really nice summary of the breadth and depth of compression garments that we have access to. Just want to remind our attendees that if you have any questions, you can put them in the chat, and we will then do the Q&A at the end just to maximize the time we're able to do the presentations. So next, I would like to invite Dr. Lohr to share her presentation on compression, not all created equal. Thank you, Dr. Lohr.
Maybe got ahead of you here. There we go.
Yeah, it's working. Lovely.
Well, I am stuck.
That does look like it.
I'm trying to get into presentation mode and it's not opening. No.
Try again now.
Yeah.
Okay, that's not a problem at all. Should we?
Why don't I go to stop? I'll just stop sharing and see if I can reopen this.
Yeah, let's try that. And I thought we can perhaps do Dr. Bunnell's first, and then we can do yours second. That will still work fine. We'll try one more time.
There we go. I think we got it.
Wonderful. Excellent. Thank you.
All right. I am a vascular surgeon in Columbia, South Carolina. I am also certified in wound care, as this field has evolved rather quickly. Now this is, I'm not sure if this is my screen or yours because this is not letting me advance. I'm gonna bug out and go ahead, let Dr. Bunnell go first, and then we'll come back.
Sounds good.
Sorry about that.
No problem at all. So whilst Dr. Bunnell is loading her presentation, this is on leg swelling and the benefits of pneumatic compression. Thank you, that's working well. I think you're muted, Dr. Bunnell.
Sorry, I had to unshare in order to unmute. Let me try this one more time. Okay, can you see this now?
Yeah, that's great, thank you.
Is it up for you? Okay, great. All right, well, hello everyone. I'm a vascular surgeon practicing in Tampa, Florida. I serve on several committees for the Society of Vascular Surgery, as well as the American Venous Forum, and I manage many venous and wound care patients and the full gambit of vascular surgery. I'm really pleased to be here and to be part of this exceptional program. I will be reviewing some basics regarding lymphedema and venous reflux disease, and I hope to speak a bit on the value of that dynamic compression, the pneumatic compression therapy, in the treatment of each of these pathologies. I have no financial conflicts of interest to disclose. As many of us are aware, lymphedema is a progressive condition that occurs when the lymphatic transport system falls below the capacity needed to handle the fluids that normally leak from the blood vessels into the lymph system. The accumulation of fluids leads to swelling in the subcutaneous tissue as a result of obstruction of the lymphatic vessels or lymph nodes. This can come from any disease process that interferes with or disrupts the normal mechanical process by which the lymphatic system collects, filters, and returns lymph fluid back into the circulatory system. There are primary lymphedema pathologies, which are genetic and present either earlier or later in life, and secondary causes such as surgical disruption, infection, radiation damage, and so on. Since the arterial capillaries continue to function normally and deliver fluid to the tissue, the volume of fluid increases significantly until the venous capillaries are no longer able to compensate for the defective lymph vessels. Lymphedema symptoms become quite apparent, usually once the lymphatic drainage has been reduced by about 80% or more. Lymphedema is a clinical diagnosis. It's based on signs and symptoms, patient history, physical exam, and imaging studies that are varying degrees of severity of lymphedema as well. This ranges from minimal skin changes to dense fibroadipose deposition. These extreme changes can cause life-threatening complications. The earlier the diagnosis of lymphedema is established and the earlier treatment is initiated, the lower the risk of developing large distorted limbs with multiple skin changes. When lymph fluid accumulates pathologically, it can reduce the amount of nutrients that reach the cells and can interfere with wound healing. This can result in an increased risk of infection. Cosmetic changes also follow, and some studies have shown increased incidences of concomitant DVT formation as well as lymphangiosarcoma. The goals of treatment are meant to effectively control the swelling, promote physiologic flow of lymph fluid, prevent the progression of the disease, and really to improve or at least maintain our patient's quality of life. These goals are best met with a combination of treatment modalities. This not only includes adequate skin and nail hygiene, but the use of multi-layer compression garments, as mentioned earlier, and in some cases, pharmaceutical support for fluid offloading. Additional surgical treatments may be available, such as full thickness tissue excision, liposuction, lymph node transfer or transplant, and lymphovenous bypass. However, these treatments are quite invasive and often have long-term complications of their own. Many patients are also not ideal candidates for these more extreme interventions, and so they're not commonly in use worldwide. Complete decongestive physiotherapy has most consistently demonstrated substantial improvement in symptoms and quality of life, and that includes your manual lymphatic drainage. Even though lymphatic drainage massage has been shown to demonstrate statistically significant improvement in swelling and quality of life, it's actually quite difficult in practice to administer to a worldwide population of lymphedema patients routinely and with consistent compliance. The literature has also supported the use of pneumatic compression, and that's what we'll discuss in more great detail today. The progression of venous return is dependent on low resistance, pressure gradients, as well as the function of unidirectional venous valves. When these valves become incompetent, venous insufficiency or reflux disease ensues, allowing for bidirectional venous flow, which in the lower extremities is usually overcome by gravitational forces and therefore builds greater fluid pressure towards the lower leg. The result of this venous hypertension is multifactorial and leads to a diverse array of symptoms. This includes spider veins, varicose veins, swelling, and in later stages, hyperpigmentation, decreased mobility, skin breakdown and lichenification, weeping, and ultimately the dreaded venous ulcer. Venous leg ulcers account for about 70 to 90% of all leg ulcers. Their healing is a major challenge which absorbs high levels of healthcare resources and more importantly causes significant distress to the patients and families that are affected. As venous insufficiency is precipitated by venous hypertension, treatment of venous ulcers requires management of the underlying venous hypertension, and really failure to address this contributes to high rates of recurrence. Sustained compression using bandaging has been the recommended first-line therapy for venous ulcers. However, there are still many individuals who cannot tolerate or are unable to comply with this therapy, and those in whom wounds simply fail to respond to it alone. Venotonics, also known as venotropics or phlebotropics, are supplemental agents used to alleviate some symptoms of venous insufficiency. None have really been shown to cure venous insufficiency or to be as effective as surgical ablation, but several have been shown to reduce some severity of the symptoms. More commonly used methods such as vein ablation and historically vein stripping or phlebectomy have demonstrated more consistent symptom improvement. However, and especially in patients with both deep and superficial venous disease, there's always some level of symptomatology that persists. With regards to venous ulcerations in particular, the use of biologic agents or grafts has also been proven to be a helpful adjunct to successful treatment. It's also important to remember that addressing any underlying arterial insufficiency and iliac venous compression in the circumstance of non-healing ulcers is critical to treatment success. Finally, we see again here that there is a role for pneumatic compression in this paradigm, and perhaps this tool is a bit underused in venous pathology. So pneumatic compression therapy can be targeted to address both the venous and lymphatic pathology, allowing for that proverbial killing of two birds with one stone. Pneumatic compression pumps sequentially increase the pressure in the extracellular space, actively forcing the excess fluid back into the circulation. As you can see, there's typically a pneumatic bladder that exerts this external pressure sequentially from the distal compartment at the foot all the way up to the proximal leg or thigh, allowing the fluid to be propagated back into the more proximal lymphatic drainage channels. The use of pneumatic compression pumps in venous insufficiency has several added benefits. When the lower extremities are compressed, blood is squeezed from the underlying deep veins and accelerated in a proximal direction. This rapid movement of venous blood results in a sudden lowering of the venous pressure. Consequently, there is an increase in the difference between the arterial and venous pressures, creating a larger AV gradient. This in turn brings about a resultant increase in arterial flow. The increased blood velocity in both arterial and venous systems causes distension of the vessels, resulting in increases in both the compressive and shearing forces on the endothelial lining. These mechanical forces have been demonstrated to cause physiologic responses in the endothelial cells that contribute to the antithrombotic, pro-fibrinolytic, and vasodilatory effects of pneumatic compression. Hematological studies have demonstrated that patients with chronic venous insufficiency have reduced plasma fibrinolytic activity. It also increases tissue plasminogen activator and urokinase plasminogen activator, with a corresponding decrease in plasminogen activator inhibitor 1. These actions have the overall effect of suppressing the procoagulant activity while enhancing fibrinolysis. So are all pumps able to give the inclusive benefits in both lymphedema and venous reflux patients? Well, the answer is no. Lymphedema pumps are typically manufactured with about 22 millimeters mercury exerted pressure. This is substantial for drainage from the skin to the soft tissue level. However, in order to truly propagate into the venous system for added fluid volume offloading, an additional at least 30 millimeters of mercury of pressure is required. And these machines are typically unable to titrate their pressure settings as is possible with venous graded pumps. Additionally, in patients with brawny indurated lipodermatosclerosis, the orange peel skin, the added soft tissue extracellular pressure diminishes almost half of the external mechanical pressure that's administered by the pumps, therefore requiring much greater compressive forces to overcome the pressure gradient. As more severe venous hypertension presents, even more external pressure is again required. And for this reason, titratable compressive pumps have an advantage for patients with venous or mixed venous and lymphatic disease. A Polish study led by Dr. Waldemar Olszewski demonstrated this and was able to show the difference in pressures achieved by a lymphedema pump, such as the FlexiTouch here, versus a venous pump, here the biocompression pump. So the proof is in the pudding. There is substantial literature that suggests these differences to meaningfully affect patient outcomes. A 2021 prospective study revealed that infection rates decreased by 32% and hospitalizations due to infection decreased by 14% after pneumatic compression treatment had been initiated. Physical therapy needs decreased by 24% after pneumatic compression. And at a median 18-month follow-up, compliance for pneumatic compression was as high as 84%, compared to a compliance level in manual lymphatic drainage of less than half of that at 53%. A cohort of 52% patients with mixed lymphedema and venous insufficiency demonstrating on average 1 year duration of non-healing ulcerations were randomized to multi-layer compression garments alone versus with pneumatic compression and demonstrated shorter wound healing times and more rapid decrease in ulcer size. Another recent study revealed a 28% decrease in absolute limb volume, significant decreases in body mass index, and significant improvements in clinical severity and quality of life scoring at 1 year. They also reported a substantial per capita direct cost savings of at least $3,200 per patient per year. This will weigh heavily on that pay per performance measure. So not only does this offer a superior value proposition for patients and physicians, but also hospitals and the healthcare system as a whole. In conclusion, the sequelae of lymphedema and venous insufficiency can both significantly affect quality of life. Their complications can further burden the healthcare system in a substantial way. Pneumatic compression devices are a pivotal and beneficial proponent of the non-operative algorithm for treating both venous and lymphedema patients. We must remember, however, that not all pumps are created equally, and it's important to understand the underlying pathology of each patient prior to committing to a specific model. And lastly, high pressure or venous rated pneumatic compression therapy is effective when used alone or as an adjunct to compression bandaging and has been shown to improve ulcer healing rates. The application of pneumatic compression is becoming increasingly recognized in this area as part of the first-line treatment algorithm. Thank you.
Thank you very much, Dr. Bunnell, for your presentation. That was really informative. Should we try sharing your slides again, Dr. Lohr? And if that doesn't work, the IT team is ready to share them for you. And if you could unmute yourself as well, sorry.
All right, we'll start with that. And sorry, let's see if this will work.
No, no problem.
We got it.
Excellent.
So thank you to the committee and the invitation to present this. I'm going to talk about how compression is not all equal. I have no relevant financial disclosures. And I need to acknowledge Dr. Hugo Parch, especially for his groundbreaking work on compression from the early years. Dr. Caprini for sharing some of his slides, and his colleagues in Chicago. You'll see a series of slides at the end from Claudia Boyle, who will discuss good and bad stockings, and I appreciate their willingness to allow me to use some of their slides and data. So edema in the leg results when there is a problem with the normal venous return of blood. Now, this could be due to obstruction from thrombosis, hematoma, tumor, or mass. You can have reflux with leaking venous valves, and you can have increased venous pressure due to morbid obesity. These factors all combine to increase the pressure at the venous end of the capillary that then inhibits the exchange of oxygen, nutrients into the cells, and removal of waste products. The capillaries then begin to dilate as the venous pressure increases. The dilation results in cracks in the endothelial lining. The white cells activate and they attempt to seal these cracks. You can have red cells that are also trapped in these cracks, and then thrombosis can result from activation of the clotting system due to the exposed subendothelial collagen. The capillaries no longer function properly, and skin changes that you see include rashes, eczema, and ulcers. Here's an example of the endothelial cell cracking, then the white cells trying to plug this all up. Those of you that haven't seen venous valves, this is what a normal valve looks like, and they'll coapt. Here's what a damaged valve looks like through the angioscope. So we have patients that have surgery and compression with elastic bandaging. Here's after a total knee. You can see swelling that is under a wrap. Pitting edema results, and they have discomfort. And you can also see here, you can get cuts and ulcers. This is an example of swelling after a skin graft that was wrapped in an ACE wrap for 5 days after surgery. So are ACE bandages inappropriate for these situations? I hope you agree. Dr. Caprini is rather strong in his conclusion, as most of the medical community, that elastic bandages, Curlix, stockinets, TED hose, tube gauze for leg swelling, venous stasis ulcers, or venous insufficiency induced lymphedema are inappropriate and below the standard of care. There's a difference between short and long stretch bandages. Here you can see the long stretch bandage, Dr. Caprini showing how much give there is, and his assistant showing you the short stretch bandage. Elastic bandages are the most frequently used leg wraps for a variety of problems. The long stretch devices have little value to control swelling, however. They fail to produce hemodynamic changes conducive for ulcer healing. They give poor pain control for tenderness relief in an injured limb, and they must be used with extreme caution for patients with arterial insufficiency. They're difficult to wear day and night. The long stretch bandages have a high resting pressure. They become very uncomfortable with time. They have a low working or ambulatory pressure, and the bandage will give way when the patient walks. The net result is a poor control of swelling. Edema may actually increase when you use these bandages because they can have a tourniquet or rubber band effect. The difference between pressure under the bandage when lying and standing is frequently less than 10 millimeters. And this is the static stiffness index, and you'll hear more about this in a minute. Here's basically what you see after an anti-embolism stocking. Patients laying down, they stand up and you see the pressure change under the bandage. They exercise and they go to recovery, and you really don't see any change regardless of their body position. Compression class 2 stockings, again, laying down, there's dorsiflexion, patient stands up, and then there's the recovery after standing. Short stretch compression results in a low resting pressure and a high ambulatory pressure. They're very comfortable at rest and when used day and night. Ambulation reduces swelling and encourages the ulcer healing. The pressure under the bandage at rest increases more than 10 millimeters when they stand. And these include things like your Unida boots, your short stretch bandages, and your Velcro devices. Short stretch bandages can be applied with the same resting pressure, more effectively reducing venous volume and reflux in these diseased limbs. Ambulatory venous hypertension can also be lowered by firm short stretch bandages with a pressure higher than 50 millimeters of mercury, which cannot be achieved comfortably with stockings. A short stretch bandage exerting 50 millimeters at rest may produce pressure peaks during walking of over 110 millimeters. This will result in the rhythmic fragmentation of the blood column, much like the artificial valve would reduce ambulatory venous pressure. This comes from Dr. Parch's early work. Examples of elastic bandages are the ACE and compression stockings. Inelastic, they're short stretch, and there's a variety of companies that make these, and the no stretch is the zinc paste or Unida boot. They have short stretch, has different materials. The pressure depends mainly on the tension when you apply it, and you control it when you apply the dressing. I'm not sure what happened to the slide here, but the stiffness is the difference, and it increases by increasing in this leg circumference. This changes with the dorsiflexion standing up. You can have friction between the layers that increases the stiffness. You can have several layers that will change the elastic properties of the final bandaging. They're higher friction with cohesive materials. You can have the basically, the ultimate is the characteristic of proportion of tolerability, which is at rest, and the efficacy, which is at work. And this is really the deciding principle. Can the patient tolerate at rest, and does it work? And this is from the International Compression Consensus document. Standing pressure is defined as the pressure minus the laying down pressure measured at 12 centimeters above the inner ankle. The ideal bandages will have a low tolerable resting pressure and a high pressure during standing and walking. There's an excellent correlation between standing and working pressure. These include the zinc paste Unida boot, the adhesive cohesive bandages, the multi-layer short stretch dressings, multi-component bandages, including your elastic layers and your Velcro band devices. So to summarize, here's a patient who had a TED hose for 6 months with pitting edema and not relieved. Short stretch bandaging for a week took care of that problem rather nicely. And here you can see the short stretch bandage applied. You can place layered dressings with 4 to 7 rolls, and you can place the Coban over the top to help stabilize this. Again, looking at what's happening under your dressing, your resting pressure, your standing pressure, your exercise pressure, and then your recovery. And this was with a 4-layer short stretch bandage over an Unida boot with a Coban cover. Again, stockings fail for a variety of reasons. Here you can see a rubber stocking removed, and the stocking does not succeed. Patients will have issues where they cut and dig, or they leave terrible marks, and it's uncomfortable. Patients, they won't wear them. This patient had been wearing a compression stocking for 3 years. It was the wrong, basically, fit. They stopped wearing it. And here you can see what happens after a period of time. Patients also can be fitted with the wrong stocking, be compliant, and still progress. This is a patient that was in a stocking that was too tight and hard to apply. She stopped wearing them. In over 20 years, she developed worsening stasis changes. She did well with the Velcro application. So why do patients fail with their controlling edema over such a long time? A lot of it has to do with the treating physicians not understanding what the appropriate compression for therapy is, or putting them in stockings or compression that's uncomfortable. Sometimes the patients just don't comply at all. or sometimes they're not able to and don't have the resources to comply. So a patient that's having difficulty may benefit from an easier or different device. Patients that are having difficulty donning and doffing may have trouble because of their age, weakness, arthritic changes in their hands or shoulders, obesity, advanced age of pregnancy, restricted mobility. They may have chronic lymphedema. The edema was uncontrolled with other treatments, and leg wounds. They may all benefit from the Velcro devices. Patients that have joint replacements that start out with preoperative swelling do very well postoperatively with a Velcro device. Patients with more severe leg edema that's uncontrolled by conventional stockings. Patients with an advanced degree of lymphedema, the venous stasis syndrome due to morbid obesity, and patients who are post-op that cannot put things on properly. So it is the only inelastic bandage that can be adjusted by the patient for comfort and consists of a series of Velcro straps that encircle the extremity. Donning and doffing is very fast, and the advantage is you can tighten or loosen them as you need to. If the edema goes down, you can tighten them, or you can loosen them if you have pain, tenderness, or numbness and compression-related symptoms. They're usually worn over a light stocking or hybrid liner with only a foot compression to facilitate application. The devices utilize a short stretch material. This features a low resting pressure, providing comfort at rest. It also achieves a high working pressure with exercise. As the muscles contract, the blood is forced out of the limb and the bandage doesn't give way. This results in a decreased residual venous volume and edema, producing decrease in the leg circumference. The static stiffness index is greater than 10, which is ideal for treating edema. So there's different kinds and different types, and they come in and they look different, but again, they all do the same thing. This is a Velcro device over a short stretch bandage, and here's one over a silver stocking. And again, when you look at the Velcro device, their resting pressure, their standing pressure, and the recovery pressure, and you can see that there's a big difference between the resting and ambulatory pressure. There's good edema reduction, and the device can be used over even a compression dressing that requires wound changes for an open ulcer. So patients with large abdominal girths have increased venous pressure due to their abdominal pressure, and this could easily exceed 50 millimeters of mercury. Your standard 30 millimeter stockings are not going to reduce swelling, pain, and discomfort in this group. They're also hard to apply. Patients can't get to them, and they can't remove them either. They get stuck at the ankle and take a scissors and cut them off. There's increased leg discomfort due to the elastic properties, and there's very poor patient compliance that actually makes the problems worse. Again, a patient that's been compliant with a compression stocking and progresses to venous ulcer because it was the inappropriate choice of device. Venous insufficiency, here you can see a problem patient with the classic buffalo hump and the positive stemmer sign and the little toes with lymphedema. This patient was successfully treated with compression and Velcro devices and lace-up shoes. Patients with mixed arterial and venous disease can be really problematic and are probably the most at risk for limb loss. The Velcro devices are ideal because they have a low resting pressure and a high working and walking pressure. They're easily adjustable based on patient's symptoms and tolerance. They could be used as long as the resting pressure is less than the systolic pressure at the ankle. The arterial inflow in some of these patients actually increases as the blood is pumped out and gives you temporary improved leg perfusion. The foot compression can be added to this if you need it. There's a specific Velcro foot piece. You could use a hybrid stocking, which has a 20 millimeter foot compression and negligible leg compression to facilitate donning and doffing of the stocking. You can put a stockinette underliner on when you have patients that have skin lesions. You can use a light stocking if you need to. You can use an ankle sleeve to control ankle swelling in some patients, and you can even add lace Velcro strap shoes to help limit the foot swelling. Patients who reach their 8th to 9th decade frequently have leg swelling. They're less active, they're overweight, they sit. These people are seen in the wound clinic with skin lacerations and ulcers. But once they're healed, the Velcro is a very good way to decrease recurrence. Relying on these patients to use stockings to control swelling is a high failure rate, and the Velcro devices are ideal in this situation. Here you can see a 90-year-old man, pitting edema, uncontrolled, and edema is gone after using compression bandages for a week. So what's the approach to control edema long-term after appropriate compression therapy? Velcro compression clearly is indicated. It's the secret weapon for controlling edema and preventing ulcer recurrence. The Circade Cure, quote unquote, are devices that are particularly useful for healing venous stasis ulcers and instead of using compression bandagings, they're higher compliance rate and have a decreased recurrence rate. You can fit them in the office to the exact leg pressures without any special expertise. And the patients could take them on and off and reapply them at home. In some cases, they're actually cheaper than some of the other options for wound care. And here are some good lesions to use for the Velcro devices instead of wrapping. So here's how you apply them. You measure the size and you put them on. And the patients, then you can mark on the things where they start or how they want to do this. And they could wear their regular shoes if they want to. Compression stockings, I think Dr. Collins went over this, are useful for leg swelling, aching, tiredness, varicose veins, ulcers, rashes, pigmentation, superficial and deep vein thrombosis. The most common use stocking is about the knee length, and they can be helpful for severe varicose veins. And in some pregnant women, you will need to have the long leg stocking. The TED hose, the anti-embolic, the thromboembolic deterrent, is really for thrombosis prophylaxis. You heard quite clearly, these are for bedridden patients. These are not for ambulatory patients. These are not effective for thrombosis prophylaxis in stroke patients who are bedridden, however. The 20-30 weight stockings are useful for the most trivial venous disorders and after therapy with sclerotherapy for small spider veins. They can be easier for older people to get on and off. They are not useful particularly for swelling, and you can have thigh length and calf length. The 30-40 millimeters of stockings, again, are the mainstay for treatment of leg swelling, aching, tiredness, and those with post-thrombotic syndrome. You can actually use this as a therapeutic test to evaluate the relationship between leg swelling and varicose veins, and you could provide dressing and support following major surgery or intervention. This is the mainstay for leg treatment. There have been two randomized clinical trials that looked at patients who wore stockings for 2 years after a major DVT, and the post-thrombotic risk was decreased by 50%. So this is the most frequently used model, the calf length. And again, this is European class 3, United States class 2. So you need to look at where you order your stockings on. I always use the millimeters of mercury so that the vendors know what I'm really looking for rather than a class. They are very helpful for pregnant women and those patients that have healed ulcers or deep venous insufficiency. This is a lifelong commitment, but you have to make sure that their arterial circulation is adequate to support this with an ABI of greater than 0.5. The class 4 stockings are useful when the lower compression fails. They're harder to get on, and they're more expensive, and they're warmer, and they're thicker fabric. Patients don't particularly like these, but if you need them, rubber gloves are very helpful in donning and doffing. They come in different lengths as well. So when you send the patient to the store, maybe you've already tried different stockings and they don't really know what they're looking for. So you see a lot of patients who say, won't wear compression stockings because they've never been properly fit or measured. And that's a problem. Much like you have a tennis shoe that you like, you probably always buy Nike or you always buy Adidas. You don't change brands because the foot plate has a certain fit to it. Our compression stockings all have a certain fit depending on their brand as well. If we go to the over-the-counter stockings and compare the extra large measurements of the circumference of the calf, they can vary from 34 to 60 centimeters depending on the style and the brand name. So patients that pick something off the shelf really are set up for failure. So again, you want to look at how stockings are made. They're nylon plus lycra or nylon plus or spandex, and this is how you get your stocking. You need to consider allergies to the components. If people have allergies, you need to know what's in your stocking and how they're made. Dr. Pounds also talked a little bit about the knit and the weave. So are they good stockings or bad stockings? High quality stockings will have a therapeutic value. They have a true gradient pressure. They support the circulation. they reduce edema, they reduce the DVT risk, and they're comfortable. Low quality stockings have no therapeutic value. They constrict the circulation. They're not an actual gradient pressure stocking. They can create deep indentations and grooves. They don't reduce the DVT risk, and they're uncomfortable and painful. So how can you tell a high quality medical grade stocking from an inexpensive one when the patient hands it to you with no tags and no labels? Well, a high quality stocking, you could look at the difference between the small and large stocking sizes. You could compare the stretch between the top and the bottom and at the ankle. And then you could look at the foot. Is it wide and stretchy, or is it narrow? So looking at this a little more, poor quality stockings, the difference between a small and large stocking is sizing primarily as length rather than circumference. This basically assumes that all large legs are long legs and will bind and constrict on shorter legs. High quality stockings, there's a difference between the small and large sizing is primarily circumference rather than length, but they do also come in different lengths. High quality stockings, the top band will stretch much easier than the bottom ankle portion. Then the low quality stocking, the top band is tighter or equal to the ankle, and the band is narrow. High quality stockings, if you look at the foot plate, because the wider foot, they can stretch and they're comfortable for a variety of foot sizes. Poor quality stockings have very low, narrow feet with no stretch. So regular large size stocking here, and the TED hose you can see basically is not a good stocking. Cheap stockings are made exclusively for non-ambulatory patients. The TED hose basically have poor size options. They have poor fit. They're non-gradient pressure stockings. They have low quality material and design. They're often uncomfortable. They bind at the ankles, and they provide inadequate calf compression. The high quality stockings can have problems as well. They can bind at the ankle. They can roll or bunch and cause binding below the knee. It stays, which is a skin safe and stocking safe glue, can sometimes help with this. And I find that especially helpful in thigh high stockings. Dotting and doffing issues can be problematic even with high quality stockings, and patients will complain they're hot, itchy, and painful after a few hours, especially in the summer heat. So how do you select the right stocking for each patient? The sheer stockings that everybody really likes and look really glamorous are too thin for patients with this kind of a leg. This leg obviously needs a heavier fabric and better containment and less binding. Stockings that bind and cut are not therapeutic. So if we look at this leg or this leg or this leg or this leg, we can see they're going to be hard to fit. These are the patients that may benefit from a custom flat knit stocking. So Velcro is ideal for these patients. They do provide the highest level of leg pressures due to their rigid nature compared to the other appliances. These devices are adjustable and patients can accommodate their symptoms and swelling. I find these especially helpful for people with congestive heart failure that have wide swings in their limb circumference. They can be managed by those that are unable to use stockings. They're ideal for patients who are wheelchair bound and have neurologic problems, and they are useful for the vast majority of lymphedema patients. And here you can see that lace-up shoes have been added to help control some of the foot edema here. So compression pumps, we just heard a great discussion of. There's many different models. They have different pressures, phases, and sequences, different indications, and I'm not going to go through any of that. So I would tell you that you can see a lot of different devices, but you need to know what pumps do and how they work to treat your patient properly. So I'm going to conclude by this slide. It was St. Pellegrinus was considering having an amputation for his recurrent ulcer. He was praying to God, and in the morning he woke up and his ulcer was healed. So what do you suppose happened? Nobody really knew, but maybe an angel came down and applied a good compression bandage. I'd like to thank you for the privilege of the discussion.
Thank you very much, Dr. Lohr. I have to say, I've certainly, as a resident, found this absolutely fantastic, because I think compression is one of those things which, just going back to Dr. Pound's presentation, in med school, I certainly didn't get much exposure to, and even during my vascular training, there isn't a huge amount of input in all the different kinds of compression. So this has been a really informative session. So thank you all for your input. I'll kick off the discussion. I'd just like to remind our participants that if they have any questions they want to ask, they can put them in the Q&A, and then we can address them live. But we've got about 15 minutes of worth of discussion time, which is great. So first of all, just going back to patient selection. So obviously we've heard a lot about advanced CVI and we've heard a lot about lymphedema. What are your thoughts about compression in patients with C2 disease? And when do you use compression, or do you use compression? Because that's certainly a topic of discussion in the UK as to whether we should be using them or not. And what are your indications for patients with C2 disease, and what is your practice after intervention? For example, do you use compression, what kind, etc. So Dr. Bunnell, if I can start with you in terms of your comments with that, and then we can move to Dr. Lohr.
Sure. You know, I highly encourage use of compression garments, even starting at 20 to 30 millimeters mercury in patients with C2 disease. Honestly, in patients who just have lifestyle factors that put them at risk for leg swelling, I recommend they start use just kind of empirically and prophylactically of compression garments that they can get to help kind of, one, delay the onset of symptomatology, and two, overall improve the way that their legs feel at work. So yes, for my C2 patients, I do recommend they use graduated compression stockings. I have them start at 20 to 30 millimeters of mercury. I do encourage use both before any further treatment and after as well. I generally offer vein ablation to patients that are C3 level and above. C2 patients are usually, if they have symptomatic varicosities, then they usually will be a candidate for things like microphlebectomy or stab ablation. And I encourage them using the compression garments both pre and post procedurally as well. Sometimes patients with symptomatic varicose veins can be on one side of the spectrum or the other as far as their tolerance. When the varicose veins can be very tender, some people find that the use of the stockings helps. Some people find that there's a lot of rubbing and it perturbs them more. But I certainly feel that once their treatment has begun, their use of the stocking is encouraged.
And how long do you use compression after intervention, say if you have a superficial vein ablation?
So I tell my patients that a minimum of 2 weeks use of compression garments after procedure is what I suggest. However, I pretty much encourage all of them to keep using them kind of indefinitely after treatment is done, as much as they can tolerate. Even once they've reached symptom satisfaction, I feel that ongoing use, especially when they're going to be on their legs during the day. I have a lot of patients that are nurses, care providers who are, you know, waitresses, all of those patients who spend a great amount of time on their feet, or even those who work at a desk for long hours of the day, building that gravitational pressure in their legs. The use of ongoing compression therapy can be beneficial in helping to kind of delay the recurrence of some of this disease. So I usually tell them, try to keep using them as much as you can tolerate. But as far as requirements, I generally require about 2 weeks after the intervention.
Thank you. And Dr. Lohr, any thoughts on the topic?
You know, there were some very early studies done by in hospital populations of nursing staff and people that have occupational hazards where they were on their feet a lot with just minor C2 disease. And those people should all be treated. I think that anybody that has an occupational hazard should be in their stockings for work. And so we do that just routinely. Actually, our hospital has worked out an agreement, and they exchange stockings, and they supply 8 pairs of compression stockings to the hospital workers twice a year to keep them from having disease. And they also will fit for orthotics for people so they don't have so much plantar fasciitis and you don't miss time from work. Some women have only symptoms at certain times in the menstrual cycle, and I tell them to use their stockings for their symptomatic time of the month if they want to. I don't intervene on C2. I rarely would intervene on C3. I see mostly end-stage patients, and they are always in compression, pre-treatment and post-treatment. And I tell them, we're not going to get rid of your sexy socks, because venous disease is a chronic disease and it recurs. We talk about weight, we talk about exercise, lifestyle modification, and then the simple things like elevating the foot of the bed and not trying to use pillows, and trying to control as much dependent gravitational forces as possible.
Yeah, I guess that's I'd completely agree. I mean, from in the UK, so certainly on the NHS, is with the National Health Service, is sometimes a little bit difficult to be able to provide everything that you can. But we do provide compression post intervention, so for 1 week though. And that's mainly because of the lack of evidence, but also because from some of the studies we've performed, there's some comfort in terms of symptomatology with respect to reduced pain or ecchymosis post-intervention, for example, after stab avulsions. But we don't routinely fit patients with compression stockings if they're class 2 disease and symptomatic. Certainly class 4+, yes, absolutely, as long as they don't have any major arterial inflow. And obviously we've heard that they're a really difficult group of patients to treat, those with mixed ulceration, for example. But for the standard varicose veins that are symptomatic, we would normally just move on to treating them as opposed to giving them compression, but that's just part of our sort of national guidance. But I think it's a fantastic thing that they're doing in your hospital with getting staff, to have stockings and things, because I'd certainly, would be very grateful to have some, and often do wear them if I know I'm going to be standing a long period in the operating theatre. So no, that's absolutely great. And the next thing I wanted to discuss is something that we found really difficult from also a research perspective when trying to set up studies looking at compression, and that's the issue of compliance. And I get that, the UK, or certainly in London, the weather isn't always great, and patients may or may not be, too bothered about having routine compression. But what's your experience with patients' compliance with compression? Because we know from the studies that, often that there's up to a 30% non-compliance rate, and that makes it really difficult to try and understand how well compression works. And what's your experience, and how do you encourage compliance in your group of patients? Dr. Bunnell, you first.
Sure. Compliance is definitely an issue where I live as well. I'm in Florida. It's bright and sunny most of the year, and most of my patients are very much interested in keeping their legs out and in the sun and not covered up by compression garments that look less appealing or that can be uncomfortable. So yeah, it's always an ongoing issue. I feel like I'm constantly having a discussion on almost every visit to try to re-encourage the importance of this and really bring to their understanding how the compression garments work and why it actually is helpful to them. Because I feel that a lot of patients, when they are sent to me, do not have a good understanding of this. They feel that, well, it just doesn't seem like it's making a difference. As soon as I take the stocking off, the swelling comes back, my achiness comes right back. So it's not like it's gone. Yes, but the goal isn't to avoid the use of compression garments by just having a surgery or procedure done. There's an underlying ongoing pathology at play that needs to continue to be managed, and that is really part of the essential treatment. And so patients come often to get their legs to look better and want to avoid that step, but I feel that it's kind of our responsibility to really educate them about why this is so important for their care. And so I feel like I spend quite a bit of time doing that with my patients. And, I still don't get, stellar compliance rates, but I do insist that they're really trying at least everything within their power to be as compliant as possible before undergoing treatment, because one, it's informative for me as far as how well they're going to do in the long term, especially after treatment. But also, if they're not going to be willing to use the compression garments after we've done vein ablations, there's going to be a limited amount of their actual improvement in the long run, especially in patients with venous ulcerations. If they have venous ulcerations and they're not willing to use any form of compression garment, they're in big trouble. They're in big trouble.
And Dr. Lohr?
Well, one of the study groups actually had sensors built in to monitor for compliance. So the answer to the research question is there are some sensors you can put in the stockings that will tell you whether they're really measuring or not. And they don't even know they're there. So that's the first thing. The second thing is the patients all basically need a lot of education. I agree with Dr. Bunnell, because they don't seem to understand long-term what's going to happen. And so I'm a big proponent of education. I also take photographs and I take measurements and I take their weight. And so you can trend for them what's happening with their limb circumference. You can show them and actually teach them the feel of early stages of edema, especially when they have two different limbs, or you can show them the ankle feel and texture compared to the thigh skin. And so a lot of it is educating about what's happening with the proteins and the buildup of the fluid blocking layers. And most of them who have had advanced disease really don't want to have ulcers come back. So once they've had severe disease, they become much more compliant. But ulcers result in so much missed time from work. But between the photographing and the graphing of the weight and circumferences, and then showing them on their own limbs what happens, you can get people to come around to compliance. The other thing we did in my office is we had a compliance navigator, a stocking navigator, who actually, we had a dispensary that would come in and dispense stockings in our office for us that had a variety of sizes and off-the-shelf stockings, so you didn't have to have customs. And so we would measure, and if there was a problem or anything, they had a contact person that they could directly call for trouble with their stockings and troubleshoot, almost like a nurse navigator. It was a compliance navigator. And that worked really well to get them in the right brand, the right texture, the right knit, the right fabric, so that it improved their compliance. And it's kind of funny. One of the questions on there was, why do you wear your stockings? And the answer on a couple of patients came back, because she's going to yell at me if I don't. Well, you have a long-term relationship with these patients, and you want to keep them out of the hospital. Some of them I'll even give a standing antibiotic at home if they've had recurrent cellulitis, with the caveat that they can start on it when they have their prodrome and the symptoms for their cellulitis. But I will not refill it and I will not renew it if I haven't seen them within a week or less. And so when they have their symptoms on Saturday, they can start their antibiotic, take their antibiotic to decrease their severity of the episode, and I'll see them the next week. And then we've kept a lot of people out of the hospital by being really proactive with good foot and nail care, good skin care. And I also tell them that Coast and the Manly soaps are for anything, the hairy parts above the knees. They have them use either a glycerin bar or Dove soap from the knee distally to decrease the drying and some of those kinds of things. So all of those adjuncts are simple things that they can do at home that aren't expensive.
I guess it's sort of empowering the patients with information on their own sort of pathology, and it's not a blanket approach. It's actually quite tailored to the individual patients. And you're absolutely right. I think, if somebody understands what the reason is, for having to wear the wretched stocking or Velcro device, then they're more likely to sort of comply with it. And we find this as well, once patients hit the venous ulcer stage, then they'll do whatever they can to try and not go there again if they're healed. And I guess the compliance and maybe patients who are not yet at that stage is a little bit more difficult.
But just one other thing on the compliance issue is I tell them all, I know these aren't the sexy socks that you want to be seen in. And so if you're going out for a special celebration or to a dinner or to something really special, you can go without them for 4 hours, but you can't go without them on a daily basis. So, it's a matter of selective compression and compliance, maybe in some of these people, depending on what their jobs are, what their lifestyle and their interests are.
Absolutely. And I was very interested to see actually in Dr. Bunnell's slide, that the compliance with the pneumatic compression was considerably higher than with manual lymphatic drainage. And I guess that's, because obviously that's something they can do potentially at home. Now, sadly, we don't have that availability. I mean, patients can purchase them, but we do have a bit of a problem with trying to get people home with long-term sort of swelling or post-thrombotic syndrome that do require intermittent pneumatic compression, and they can have them in hospital, but it's very difficult to get that at home. So just in literally the last 2 minutes, is it any easier in the US? Do you have a different setup that you can get these sort of intermittent pneumatic compression devices at home for your patients? How does it work?
So, a lot of it is, it's really dependent on insurance. Right. And, the typical Medicare patient has excellent coverage for things like this, which is great. But, the requirements are generally patients who have lymphedema, who failed other conservative management, or venous ulcerations that have been present for at least 6 months, or venous insufficiency that has failed other therapies as well after a certain period of time. So it does take quite a little bit of work to get them approved for these pumps. I have almost no patients at all that I can recall that have paid for them out of pocket, or that have been willing to pay for them out of pocket. So we work really hard with with the device companies to really help facilitate getting them approved for coverage for this. And so they are seen on multiple visits at our office. They're sized and have consultations for lymphatic and pneumatic compression pumps. And then they are put in contact with a representative from one of a few different compression companies that we use. Then they come out and visit them at their home after they've kind of organized and ordered the appropriate device for them. And then they do a bunch of patient education with them at their home. So they understand how to use it, what to expect, how to troubleshoot, and who to reach out to when they're having problems. So I found that it's very beneficial. I've been using it more and more in, earlier parts of my treatment algorithm for patients with severe venous insufficiency, venous leg ulcers, and pretty much all of my lymphedema patients as well. So I think it's very beneficial. I do know it's a challenge to get them. I think it's probably easier here, from what I'm understanding of what you're describing, for them to get it home here. And I think that's a big part of why the compliance is greater, is because they're able to use it at home. With the manual lymphatic drainage, not only is it taking them out of their home to find the time and the, transport, which is an issue for a lot of my patients, to go and get this done, but also there's not an exorbitant amount of providers that offer MLD. And so finding occupational therapists and so on that do this can be part of the challenge as well. And so, yeah, the compliance is not as great with that, not because it doesn't work, but because I think there's just some barriers to the accessibility. And so that's kind of one of the things that we continue to try to work on.
Yeah.
A couple of things to add to that. We actually bring in their partner or their spouse and have the therapist teach their partner how to do manual massage. And so we basically call it a team sport. And so we teach their significant other how to be involved in it. And that's helped increase some of the compliance at home with the manual decompression. The other thing that we did have in our office was this kind of sad, but patients that would expire would bring their pumps in and donate them to somebody that couldn't buy one or couldn't afford it. Some of our people have no insurance, no availability. So they would be refinished and they would get a recycled pump or reused pump donated by somebody that couldn't use it or had an amputation maybe and lost their limb. So again, that's another resource that we were able to help facilitate some of the patients with.
That's a really great point, actually. I think we're out of time, sadly. Thank you to our presenters. This has been a really informative and fantastic session, and for your comments on our questions. And we'll look forward to seeing everyone on the 7th of May for our wrap-up session for the EmPowHER sessions for this year. Thank you all, and have a lovely day.
Thank you.
Thank you.